We call Dr. Robert Kramer. He's the next speaker, and he'll be speaking on prediction of recurrence of the sarcoma treatment. Can we help plan the follow-up, sir?
Thank you very much. I'm going to talk to you about follow-up, something that there is a lot of confusion about at the moment. These are the UK guidelines for the management of soft tissue sarcomas, and you will see that it says that there is very little published data about specific protocols. Lots of people have different regimes, and we don't really know whether early detection of local relapse or pulmonary metastases actually improves prognosis, and we talked about this earlier in the conference. So I created a database at the Royal Orthopaedic Hospital in 1986, and it's now got details of more than 8,000 bone and soft tissue sarcomas. We've got very good follow-up, and we know why the patients died, and we've got risks of local recurrence and metastases. And for primary tumours, 51% develop metastases, and our overall local recurrence rate was 14%. And if you look at the time to metastases by the UICC stage, it follows exactly what you might expect. People with big, high-grade tumours, stage 3, do particularly badly. But even with low-grade tumours, 1A, there's a risk of metastases. We took this a bit further, and we did multivariate analysis looking at factors that lead to metastases. And you can see, not surprisingly, that grade comes into it, that margins are actually significant, and amputation has a high hazard ratio of 1.7. And the reason for that, of course, is that we only do amputations on big, bad tumours. And age is significant, size is significant, not surprisingly, and males do worse than females. So those are the factors. And if you actually add them together and give a composite score, you can get a number of factors here, very low risk to very high risk, and it's remarkably like the UICC staging. What about survival after diagnosis of metastases? And the median survival of all our patients who develop metastases was just 10 months. But there's a tail out here of people who have long-term survival, and it's about 10% you can actually cure. This is important because this shows the survival after you get metastases based on when you get them. And if you get metastases more than 10 years, your median survival is 3 years, compared with if you get them in the first year, when your median survival is less than 12 months. So late metastases do better, but we know that already. But this is the most interesting graph of all. This shows the probability of developing metastases in the next year. And this is a high-risk group based on those criteria I looked at earlier. And this shows that in the first year, if you're in that high-risk group, you have a 26% risk of getting metastases in the next year. Even if you survive that, you have a 26% risk of getting metastases in the next year, then it drops to 12% and so on. If you're in the low-risk group, you have about a 3 or 4% risk of getting metastases, but that risk hardly changes over the next 20 years. So, in fact, high-risk patients have a higher risk of getting metastases up until about 7 or 8 years, when their risk becomes the same as intermediate risk and low-risk patients. And this may help us stratify which patients we follow up more aggressively, because you may talk to the patient and say you've only got a 4% risk of getting metastases. Maybe we won't follow you up so often. When I first qualified, we used to say that patients who were alive at 5 years were cured, but this is not the case. If you are disease-free at 5 years, you still have a significant risk of dying of metastatic disease. 8.6% chance of dying in the next 5 years, 20% chance of dying in the next 15 years. So this is not good news, and it suggests that maybe we should follow up our patients more aggressively and for longer. Local recurrence you can also predict, and this is not surprisingly. It shows you that wide margins have low local recurrence rate, better than marginal, better than intralesional, and those are low-grade, intermediate-grade and high-grade tumours. So the worst ones, interestingly, are intermediate tumours and high-grade with intralesional excision. And the risk factors for local recurrence are largely known and are there. And again, you can do a graph with the risk of local recurrence based on this. When did local recurrence arise? Clearly very high risk, get it very quickly. Very low risk, you're still at risk of getting local recurrence. That curve is still going up at 14 years. And what about late local recurrence? 10% of all local recurrences arrive after 5 years. And this is a similar graph to the metastases one, just showing that the percentage risk of local recurrence per year can be worked out based on all this information. So very high risk patients, 19% risk in the first year, dropping to 15% in the next year, and then gradually decreasing. And even low risk patients have a small risk that gradually tails off. So all this data can help us plan how you might follow up patients. I don't say I got the answer, but big data analysis like this can help you plan and make you discuss with the patient what the likely risk is. And it means that we can start to individualize patient follow-up.